It's unusual to have such a lovely intimate webinar, so I'm going to make the most of it. Hello, Steph. It's Anna Stephenson, Manager of Rural Programs with MCCC. I just wanted to welcome you this evening. And we're going to kick off. We've got a very intimate webinar. I am recording it for people who aren't able to attend, but feel free to tailor this session to what you need, all of you. You have two compatriots with you. And I want to firstly introduce Dr. Amanda Cohn, who is practicing. Take it away, Amanda. Would you like to introduce yourself first? And then I'll come back to the start of the presentation.
Yeah, absolutely. Before I introduce myself, I should say that I'm zooming in from Wiradjuri country tonight that was stolen and never ceded, and I'd like to pay respects to elders past and present, and in doing so also acknowledge the role that we've all got as health people in closing the gap. So my name's Amanda. I'm a GP registrar. I'm about to finish my training. I've just passed my exams. I work in a community health centre called Gateway Health, which is in Wodonga. And I've lived in Albury, Wodonga since I was a medical student. So I moved to Albury to study at the Rural Clinical School and absolutely fell in love with this community and stayed ever since. So I did my internship and residency at Albury Wodonga Health, spent a little bit of time in ED. I did a certificate of ED, and then I left to come out into GP land. I work part-time. I've got a whole number of other hats in the local community, and one of those hats is also working for MCCC as the registrar liaison officer. So I talk to GP registrars from all across northeast Victoria on a regular basis. So hopefully that can help answer as many concerns and queries as you've got, because I can speak to all of their experience as well as my own.
What an amazing intro, Amanda. That's fantastic. Thank you very much. And Chris, would you like to introduce yourself before I kick off with our presentation?
Yeah, absolutely. So probably not as impressive as Amanda, but so I'm a GP working in Wangaratta. I did my training with MCCC based in the northeast. I'll discuss that in a little bit more detail later. As I mentioned before, I trained through Agpt and did an advanced year in anaesthetics. And yeah, what else? I'm obviously doing work with MCCC at the moment as a medical educator, and did a role as a registrar medical educator as part of my training time. And that's about all at the moment, but I'll go into things in a bit more detail later on tonight.
Thank you very much. And and Amanda she's saying, oops, she should have said she's an Racgp registrar on a rural pathway. I love the oops, that's fantastic. I'll just start sharing my screen. This is the more formal part of our hour together. Just bear with me. Can everyone see that clearly? All good?
Yes.
Okay. So everyone tonight, I think, is more than well aware. I think you're at a stage probably of decision making, so I won't go too much into the fact that we're focusing on the Australian General Practice Training, the Agpt program today, and I know that Emma, you are interested in an IP pathway, but this is useful for you too, I think. I hope it will be. So as you know, it's funded by the Australian government. There are the two GP colleges, which goes without saying, the Racgp and the Australian College of Rural and Remote Medicine. And there are 9 regional training organisations, of which MCCC GP Training in Western Victoria is one. We cover a very large footprint, which we'll go into. As you can see, we cover almost 3/4 of the geographic area of Victoria, and we have as such we have a really large array of opportunities. When I come up to it, I'll also show you some of the 40 odd practices that you can choose to do your training in, as well as the, you're probably well aware of the health services within the region. But there are I think there are about 47 practices within northeast Victoria alone, spread throughout from Kilmore to Mansfield, Mount Beauty, up to Corryong, Wodonga, Shepparton, and along the river at Corrowa and Cobram. So there's a very large array of opportunities that MCCC can offer you in terms of placing you in practice for your GP training. You probably are well aware that GP has got such a great opportunity to provide continuity of care. This is something that I think you would be well aware of in your decision-making process as to where you are now. And also that not only with a rural pathway, but a rural generalist pathway, you can subspecialise in anything from paediatrics to palliative care, and that you have a greater degree of flexibility and autonomy to work where you want and when you want. And how could we forget the support that we not only provide with MCCC, but in terms of a dynamic and supportive working environment when you are working in practice. So as you know, we are inviting applications to Agpt in the second intake. We have approximately 33 places currently available to people wanting to enrol in a rural pathway, and that does include rural generalist. At this stage, that's the FAR GP pathway with Racgp. And as you know, that the Racgp application process will close on the 30th of September. I'll just put all of this up rather than make you go through it all. I'm keen for Amanda and Chris to probably, rather than do the generic PowerPoint slides, this is the kind of thing that I think we can talk about as we go through the presentation tonight, is the training experience with MCCC, the kinds of opportunities that are available, the clinical and procedural skills, which I think you all are familiar with, you at that decision-making time in your training, and that MCCC has really moved to provide very well supported online and face-to-face COVID safe education. Is everyone familiar with these pathways? I just don't want to be, putting you through something that that you may already be familiar with. Are there any questions about particularly the rural generalist pathway with VRGP or the Racgp pathway to GP training? Any questions at this stage?
Yeah, so I get a bit confused between the rural generalist, the ACRM and the FAR GP, because they all seem to be quite overlapping, but they're very separate on this slide.
Amanda, would you like to take that one?
Yeah, look, this is a really common question, and I think the reason people get confused about them is because they are very similar in terms of what your day-to-day life in practice is going to look like as a registrar, regardless of which one of those pathways you're on. So ACRM is obviously a college that really just does rural generalism, so that you're sort of specialising in that automatically by doing ACRM, and it's a separate college that specialises in that. The Racgp has started to offer its own program as well to try and attract registrars who are interested in that sort of thing. So they've got what essentially is a competitive offering with ACRM, which is the FAR GP. And the content is extremely similar. And when you train with MCCC, you'll actually be in the same practice with the same supervisor regardless. So it's just at the paperwork end which pathway you're on makes the real difference. Your day-to-day practice is the same. And the rural generalist pathway, that's a new thing that's basically designed to help streamline you through that process, because they've tried to make it easier for people. So obviously when you're doing ACRM or FAR GP or rural generalism, you need to do that extra 12 months subspecialty. And when you do that through the rural generalist pathway, it's all kind of lined up for you, and that hospital post is included in the pathway. Whereas if you're doing ACRM or Racgp without the rural generalist pathway, you have to sort of apply for those posts separately on the side and tick them off rather than having it be organised for you.
That's a fantastic description. Thank you very much, Amanda. And just to follow that up, it's that case management approach to VRGP where you're joining up in a pipeline where they're helping you to manage all the transitions between the various parts of your training. We do that with MCCC, and we work very closely with VRGP to be able to do that. The other thing that I thought I might get Chris to talk about too is the need to train in MM3 and above, with a rural generalist pathway. Chris, do you want to just add anything around ACRM and also that need to train in MM3 and above?
Yeah, so ACRM basically has a rule that for your core generalist training, so that's when most people do their GP time and work in a smaller regional rural centre, does need to be MM3 or higher. They do, for things like your advanced skill years or certain specialised posts, if they're not really options in MM3 and above, you can do them in, say, larger regional centres or sometimes even in the city. But the majority of your training does need to be MM3, which is anything from sort of your towns of 50,000 people and less, really. That's sort of a rough guide of looking at things.
Is everyone familiar with the modified Monash model? Are you familiar with the kind of rough layout of that?
Yeah.
Yep. Basically, for Victoria, if you're looking at MM3 and above, you're excluding Melbourne, Geelong, Ballarat, Bendigo, Albury-Wodonga.
Albury-Wodonga, yes.
Yeah, and that's probably it. Everywhere else would be MM3 and above.
Thank you very much, Chris. Any other questions for Chris about the ACRM pathway? I know that it's the, in terms of AGPT, that's closed now, but Emma, have you got anything else you wanted to ask Chris about ACRM?
I was just going to ask about the order, the way that it's lined out there in the slide. I understood that maybe your advanced skill didn't have to necessarily be there. Is that a flexible thing, or?
Yeah, that's completely flexible. So that's just the way they've put it on the slide. That advanced skill could go anywhere, provided it's after your core generalist training that first 12 months. So yeah, that could be in year 2, it could be year 3, year 4. So I did mine halfway through my CGT time. So I did 12 months in general practice, did an advanced skill, then my final 12 months in general practice. So yeah, that's completely flexible.
Great. Thanks.
That's terrific. Thanks very much, Chris. And this is the obligatory slide where we tell you, and we mean it, because you've got 2 people on the webinar this evening who basically are so delighted to share their experience. So we really, the culture and the approach of MCCC is really about supporting our registrars and making sure that they have personalised pathways, whether they choose rural pathway or an RG, ACRM or Racgp.
I'm happy to speak to this one, Anna, because it was something that really struck me when I started GP training compared to being a resident in the hospital, was the quality of the teaching, because the majority of people that teach in hospitals from other specialties have never actually been trained to teach. They're doctors who are very good at their own specialty and just kind of teach on the fly while they're at work. And the key difference, particularly with MCCC, is that the medical educators and the GP supervisors have actually had specific training in how to teach. And it's overwhelmingly better teaching. And I think that's really important. And it's the in-practice stuff sort of with your weekly meetings with your supervisor, but also you have workshops that when I started were once a month face-to-face. I know a lot of them have turned into webinars now, but having that really dedicated time where you say, right, the whole day is just teaching today, and here's the topics we're going to cover, and they're so critical to your day-to-day practice. That kind of you know, the fact that you're actually paid to have a day off to go and learn, you don't really get that in any other training program.
Any questions about MCCC training from any of you?
I'm not sure if this is right or not. I just heard something about the colleges taking over the kind of training pathways. How does that, is that true, first of all? And second of all, how would that change things for the MCCC?
Amanda, I'm happy to take this, or you can either, probably from your perspective, I think it's good to talk about it, or Chris, either way.
Yeah, look, I'm happy to. I get this question all the time as the Registrar Liaison Officer as well. So that is true. That's a good question. So Racgp is taking over the training. What that means for registrars who are in the middle of the program when that happens is not a big change, except the sort of bureaucracy behind the scenes. You will be doing the same work day to day in the same practices with the same supervisors and the same educators. So at the end of the day, all the people that do that work to support you, you know, they'll be employed by Racgp rather than by MCCC. But you know, on the ground in whatever town you're going to be, I think it's going to make very little difference to day-to-day life for registrars.
Have you anything to add about ACRM in that perspective, Chris? Anything you want to add to that?
Look, no, I agree with everything Amanda said. It probably won't change a whole lot for the registrars on the ground. It might, if anything, for ACRM make things even more flexible, because there are certain MCCC requirements that ACRM doesn't necessarily have in terms of, say, geographical restrictions, which might change with ACRM taking over. So there might be additional flexibility. The education program will certainly change, but in what way, we're yet to find out. But it shouldn't have any great impact in terms of your decision making in terms of applying for AGPT or MCCC or not. Because it's probably not going to make a realistic difference at this stage.
And just to add, Emma, just for everyone, is that we are working, MCCC is working alongside both the colleges to transition. So it's not like, oh, well, goodbye. We're working in a transition process so that our main focus is to make the transition as smooth as possible for our registrars so that they get a seamless and quality education.
That's great. Thank you.
That's really great questions. I love these intimate webinars. I think we should have more of them. So, but no, thank you. So in terms of your AGPT2 intake options, as I said that we have 33 places that are available to people wanting to do a rural pathway or a rural generalist pathway with Racgp. And so therefore, there are no metro places at this point in time. So, from polling the large number of people on the call, I don't think that that was what you were looking for. But so essentially, has anyone got any questions about eligibility or, you know, sort of any concerns they have around entry at this stage? No? Okay, I'll continue on. Okay, as we've said, you can consider advanced skills. There are remaining advanced skills if you are practice ready in the Northeast as well as in the Northwest. I think Steph, you're looking at the Northwest as well. So basically at this stage, there are advanced skills posts at Albury-Wodonga Health. I'll just get up my information. At Albury-Wodonga Health, Goulburn Valley, GV Health and Northeast Health. So basically there are posts in emergency and paediatrics and O&G, I think, at the moment. So that is an option still for people that normally wouldn't be available, but if you are practice ready, there are opportunities. There are also opportunities for people coming into the Northeast if they're practice ready to be placed in a practice in this intake too as well. Any questions about that at this stage? no problems. So I might just, I'll come back to the rural generalist training. I might just hand over now to Amanda to talk about her experience. And even though you've basically given a little introduction on why you're training in the Northeast, can you tell us a little bit about why you chose to go rural?
Yeah, I think I've told you why I said to live in Albury-Wodonga, but I think folding that into why I picked Racgp rural pathway with MCCC is relevant. So one strong reason for that was that I'd established my life here. My partner lives here. He's not a doctor. We've bought a house in Albury. I'm a member of a whole bunch of different community groups and clubs. And when I was picking my specialist program, I didn't want to have to move. And most other specialties will make you do a number of years in a tertiary hospital. Even GP training, if you start off in the city, you've got forced rotations in that metro pathway of either 6 or 12 months in another town. And by doing Racgp rural pathway training, I could stay in one town, being Albury-Wodonga, so it's MMM2, so I couldn't do Akron here. It's exactly the size of town I want to live in, and I can do my entire training without moving house or spending any time away from the community that I live in and I love, and that was really important to me. You do have to do a short period of time in another practice, but the majority of big towns, I know we've got people on the call from Wangaratta and Bendigo and Shepparton, those sorts of places have got multiple practices that are accredited for GP training. So even if you're split across two practices, they might just be down the road from each other. So that was so important to me. The other one was control over my time. And, as someone with kind of a lot of interests outside of medicine and a lot of different hats, it was really valuable to me to be able to train part-time. So I only work in GP practice 3 days a week. And I've been able to choose which 3 days those are, which is really valuable to me. And by choosing to train in a practice that doesn't do after hours or on call. So obviously some practices do have hospital work associated with them, in small towns or after hours work, but some practices don't. So I chose to apply to a clinic that is not open after hours or on weekends. And that was really important to me. I can guarantee that my GP time is those exact 3 days a week, 9 to 5. And that really let me have control over my time to be able to pursue a whole bunch of other things. And I think that level of control of your work, you can work more if you want, you can work less if you want, you can subspecialize in so many things. I know we've talked about sort of formal specialization tonight, but there's so many other opportunities just to have special interests in things as a GP. So as an Racgp trainee, you can do a 6-month extended skills post, and that can be things like skin cancer clinics. So the opportunities are just incredible. The clinic that I work at the moment in community health is one of the only clinics outside of a capital city that does gender affirming care for young people. So learning about transgender medicine has been an extraordinary opportunity, and we're also the clinic that does health assessments for newly arrived refugees. We obviously haven't had any recently because of COVID, but that exposure to using interpreters, infectious diseases, chronic conditions in really advanced stages you wouldn't normally see. It's just been absolutely fascinating, and that's all been in a big town as an Racgp trainee. So that's just been.
Can I just pause you there and just ask, has anyone got any questions about extended skills? Because they're different from an advanced skill. Anyone want to, or just curious about extended skills in any way?
Yeah, I don't really understand the difference between the extended versus advanced skills.
So the advanced skill is that sort of formal subspecialization, as it were. So if you're getting your FAR GP as a subspecialist pediatrician or as a DRANSCOG or as that's a very formal process. Extended skills are 6 months. They can be 12 months, I think, very rarely with extra time, but they can be 6 months of your sort of standard GP training. And it's not a formal specialization. It's just an opportunity to extend your skills in a particular interest area. And I might copy and paste the list in the chat so you can see the list, because it's just tremendous. So things like sexual health, addiction medicine, alpine medicine up at the Snow, Falls Creek, Mount Beauty, skin cancer, as I said, pediatrics, development, forensic medicine, medical education. So there's just a whole variety of things that aren't, a formal subspecialty with a college, but it's an opportunity to gain that experience in a niche kind of special interest area as a GP, if that's something you want to have in your skill set later on.
And just to let everyone know that I am going to go through the rural generalist and advanced skills information after Amanda and Chris have been speaking to you, and which I'm sure we can actually all have this wonderful discussion together, this conversation too. Any other questions about extended skills? So Amanda, tell me about, you've talked about your training experience with MCCC. Where do you think you're going to go? You've got a part-time career, you've got a really rich community life. Any thoughts about where you're going?
Yeah, it's a great question. I love the clinic that I work at the moment. I would love to continue to work there post-fellowship, so working in community health. But post-fellowship, there's so many other sort of rabbit holes you can go down with a special interest. And one of my other community hats is I chair the broader domestic violence network in Albury-Wodonga, and I do a lot of work as an activist and an advocate for domestic violence. There's an on-call GP in Albury-Wodonga who does the sexual assault service, which is forensic medicine, and that's something I'd love to apply for once I'm a fellow to kind of further my medical interest down that path. As I said, I've done a lot of work with transgender young people working in the clinic that I'm in, and I think progressing that service locally is really interesting and something I'd like to continue to upskill in as well.
And to me, what's interesting, I'm not, I'm an enabler of medical training rather than somebody who's going through medical training. But for me, when I listen to that, it just shows the huge array of opportunities that are available in regional training. And I'm sure you guys are getting to know that in the hospitals that you're currently working in. But, I think particularly there isn't a strong understanding sometimes of the huge array of opportunities, training and professional development opportunities that exist in regional training. So that's a really fantastic insight. Thanks very much, Amanda. So now to put you on the spot, can you think of your 5 top tips for making a life and a living as an RACGP trainee?
Yeah, I had a go. I've got 4. I have 4
That's good
ones, and I thought rather than add a crap one at the end, I'd do 4. So my first one, particularly in regional communities, is to get involved in the community outside of medicine. And it's something that's made my experience in Albury-Wodonga so rich. And I think doctors kind of fall into this habit of socialising with other doctors or joining, sports groups for doctors or for medical people. And I think you miss out on what's happening in the community by doing that. So, if you've got kids, joining with the local soccer club. When I was a medical student, I first arrived in Albury, I signed up to volunteer with the State Emergency Service. I just met incredible people doing that and learned skills I never thought I'd have. So top tip number 1 is sign up for something else in the community that's not related to health or medicine at all to really experience the richness of that community. My top tip number 2 is just to be curious. Be curious about medicine and be curious about people and your patients and their lives, and you'll never ever be bored. And I think there's this reputation that GP is coughs and colds and medical certificates, and it just can't be further from the truth. I think it was my first or second week as a registrar. I inherited a patient who's got Langerhans cell histiocytosis, which I'd never heard of before I started GP training. And all of her specialists are not local, they're not in town, and I provide the majority of her care. And so I started straight away, having to learn about this really interesting, rare condition. And I think if you've just got that curiousness of wanting to learn stuff, GP can just be the most interesting career. My third one is to try and define yourself in 3 different ways. I was given this advice when I graduated from medical school, and I give this to the students that I teach as well. So one is you're obviously a doctor, but try and have two other ways that you define yourself. You know, it might be that you're also a mum, that you're a Tigers fan, that you're a cello player, that you're a skier. So, you know, whatever it is that means something to you, try and have three ways of identifying yourself. I think that's really important on the days where medicine goes bad. You know, we all make mistakes in practice at times, or have things that don't go well, or we find things really stressful and burn out a little. And I think just having those other aspects of your identity to then be able to fall back on mean you don't lose yourself when that happens. And my very last one, which is really relevant to all these different pathways of GP training, is just that your career is not a race. Nobody ever got to 65 and went, gosh, I wish I'd gotten my fellowship 1 year earlier. I think there's this real trap with junior doctors that you're like really hungry to just finish and fellow as quickly as possible and move on to the next thing. And I think the beauty of GP training is that life as a registrar and life as a fellow are actually very similar. Your day-to-day life is kind of the same, and you've just got loads of support as a registrar. So take the time to you know, do those other posts, to learn about things you're interested in, work part-time if you want to. You're not going to regret the time you spend. I think rather than just looking forward to the next step of your life being over, you spend so many years as a junior doctor in training, you know, live your life during that time, and you won't regret that.
Can I say, I reckon that's equivalent to 5. It's 4, but it's equivalent to 5. Thank you very much, Amanda. Any questions for Amanda, or any probing insights that you'd like to make from anything you've heard Amanda say? This is where I should be throwing Freddo frogs at you, or pizza, if we were face to face. Thanks, guys. Chris, can we move to you now? As a fellow GP, can you tell me a little bit about your experience and why you chose to become an ACRM fellow and to choose this pathway?
Absolutely. I think, so I grew up rural, so I grew up down on the Ballerine Peninsula. So I always preferred living in the country. So that was one reason. It wasn't until fairly late in medical school that I decided that I wanted to do rural general practice. So all through med school, I would flip and flop from one specialty to the other, and basically every training placement that I did, I would sort of fall in love with that specialty and imagine myself doing that. But what I found is that towards the end of every placement, I would start to get a bit bored of it, and you'd see the same sort of presentations time and time again, and I would start to miss the other aspects of medicine that you wouldn't see in that specialty. And that drew me somewhat to general practice. So then in my final year, I did an elective in rural general practice up in Omeo, which for those of you who don't know is in the middle of nowhere in high country Victoria, about 2 hours from any other town, surrounded by nothing but mountains and bush. And basically spent 6 weeks up there seeing 3 or 4 locum GPs who would come for a week or 2 at a time and manage anything that came through the door. So the week before I got up there, one of the GPs managed a rollover that resulted in a flail chest and emergency transport out there. And then there was a sudden childbirth not long before that. And then not long after I left, there was another tractor rollover and someone had, again, pretty horrific injuries. So, and that just sort of blew my mind in terms of what general practice could be. And that was the first placement I did where I wasn't bored by the end of it. And I was actually quite upset to be leaving and going back to sort of a placement at a tertiary centre. So that's what settled rural general practice in my mind is what I wanted to do. That variety. And then, basically, so I did my internship in that Bendigo Hospital, and then have been jumping around the northeast to a few different places like Benalla and Yarrawonga and now Wangaratta. And I've settled down here for the time being and still don't know exactly where I'm going in terms of longer term plans, but that's the joy of general practice. It can, the flexibility is endless. And I think as Amanda will probably soon find, is that flexibility and the choices are somewhat overwhelming in terms of what you can do. You could finish your fellowship and then never set foot in a general practice again and do ED work or other subspecialty stuff or medical education or politics or whatever. Like you can choose an infinite amount of possibilities for what you want to do. So that for me was kind of the main appeal.
And can I ask, did you mention your advanced skill? Did you mention?
Oh yes, so I did 12 months in anaesthetics, which absolutely loved. And so I did a bit of that, and then consolidated that in the final year of training. And then for reasons such as a global pandemic and family reasons, I've put that on hold for the time being, to be a bit closer to home. But again, that's something that's up my sleeve for potentially picking back up down the track. And it's, like it just shows it's one of the many opportunities you can get as part of your training with whatever college you go with. So yeah.
Have you found it difficult to get the kind of placements that you found were enriching? Like, has that been hard for you? Or have you generally found you've been able to find in your training, were you able to find the kind of placements that fitted with what you wanted to do in your pathway as it's emerging? Yeah,
absolutely. So I think every placement that I wanted to do, I was able to do, and lucky enough to get the position. I mean, obviously sometimes there's problems with some of the more subspecialty placements, like there might only be one position a year in something, and if you're unlucky enough to miss it, then you might not have things line up exactly as you want. But the good thing about the Rural Generalist program starting up, which wasn't there when I was going through, is that the whole aim is to try to streamline things and set things up a year or two in advance sometimes, so you have that certainty. So if you say, look, I want to do anaesthetics, or I want to do obstetrics or palliative care, and I'm planning to do it in 2-3 years' time, they can potentially lock that in for you. So you might be able to do what Amanda did and stay in the one place for the duration of your training. So MCCC and Rural Generalist program are doing a lot of work to try to make things easy for people and give them the placement that they want.
And is there a typical day in the life of a GP? Is there a way that, or is it's just like that's like just, you couldn't even touch that question? Yeah,
look, like I was saying, so, I mean, you might have a typical day in the life of one GP, if you're just talking about one person. But in terms of comparing one GP to the next, you'd be hard pressed to find a rural GP at least that have two identical working weeks. So what Amanda is doing is very different to what I'm doing and the type of work that I'm doing currently. And I can't think of anyone else who has a similar sort of working week. And that, again, just highlights the sheer variety and flexibility you can have, especially in the country.
Have you found any ways, either of you, I know, Amanda, you're doing part-time, but Chris, have you found ways to get that work-life balance right? Or is that just, something that it's not attainable? I know, Amanda's, you've built your career like that, or at this moment, but I'm welcome, sort of comments from either of you on that.
Yes, I think I've certainly found it now in the latter part of my training. When I started doing medical education work for MCCC, that helped a lot because it's a completely different type of work. You're not dealing with sort of patients, and it's a different style of sort of thinking, and it just breaks up the work. And that was a big help to me, because certainly 5 days of office-based general practice is intense and draining, and I can think of very few people who do that, and would be a very hard thing to sustain. I think at the first year or so of training, I got into that trap of wanting to finish as quick as I can, and I was working full time, and whenever extra shifts or things would pop up, I'd be like, oh yeah, I can do that, and was pretty close to burnout at times. And certainly in hindsight, it probably would have been good to drop back to the part-time or not overburden myself with all the opportunities that are sort of thrown at you in terms of work and educational things. But certainly now I've got that balance, and if I wanted to, I could go to 1 day a week of something, or I could purely do education work or anything basically. So you've got that flexibility. You'll never, you should hopefully never get bored in what you're doing and never feel like you're trapped.
Because I think that's, one of the perceptions, isn't it? That if you're a rural regional GP, particularly in a smaller community, that you'll be trapped basically, and at the beck and call. But you're finding you've got a nice balance going now, Chris, by the sounds of it. Yeah,
absolutely. And look, obviously I'm not working in a really isolated small town where I'm the sole GP, and certainly there are places like that which certainly historically have been really difficult, and certainly there are places now that still would be a very difficult job to do as a sole GP. But there is a big push, especially with the Generalist program, to make those positions and towns more sustainable in the long run, and to get more GPs in there and enable more time to have holidays and breaks and not be on call 24/7, because it's not, we know it's not sustainable, and it's not what people are wanting to do. So it's fortunately things are improving in that area.
And what I've taken from both of you is the flexibility. Amanda, did you want to add anything? I know you've really, from what I hear, you deliberately crafted this. Well, it may not be a balance. It may not feel like a balance, but
I think I don't have work-life balance. I've got work balance.
Yeah, exactly.
Between medical work and non-medical work. And I think what I wanted to jump on was what Chris said about clinical GP work is actually really challenging compared to your hospital job as a resident. You come out as a GP reg in your first year, and you're seeing a new patient with a new problem every 15 or 20 minutes. The cognitive load of that is actually really, really hard. Your work days might be shorter in hours, but they're probably more exhausting mentally. And there's a real emotional load too that comes with getting to know people really, really well. You deliver bad news to people that feel like friends. So, GP work is hard. And I think, we talked earlier about those extended skills posts and kind of what are they and why do you do them? A lot of people in their second year of clinical work might do one of those part-time and their clinical work part-time. So like I know Chris did medical education. So you might do 2 or 3 days a week in clinical practice and 2 or 3 days a week in a skin clinic or doing education or academic research, or the registrar liaison job that I do is one of those. So there's all sorts of other ways you can do kind of work that's interesting that, tickles a different part of your brain, rather than that kind of grind of doing similar things day to day. And I found that really, really valuable. And the GP program was really built to help you do that, to build whatever kind of variety you want into your work time. And I think there's kind of this stereotype of kind of work-life balance just means you want to spend time with family or do sport or something else. And I think for me, that work balance, it's not just about keeping me happy, it actually makes me a better doctor. And I know when I've, in my 3 days that I'm at work, I'm ready to be there. I'm excited to be there. I've had 8 hours of sleep. I've had coffee before I start, and I can really be my best self for my patients. And I know that if I were doing more hours or more of the same thing or working, back when I was a hospital resident, you get to that point of kind of grumpy and burnt out and disinterested in what you're doing. And I never want to be like that. So I think that's the real value in finding balance. It's not just your own happiness. It actually makes you a better clinician.
And Chris, your 4 or 5 or 3 top tips? How many top tips? Maybe not 12, but yes, a small number of top tips.
So I did come up with 5, and we've covered them, some of them already, and certainly some are similar to Amanda's. So my first one, which is exactly the same as Amanda's, was don't forget your life outside of medicine. It's very easy to get caught up purely in sort of medicine and jumping through the hoops and getting through the program, and you'll get thrown all these fantastic opportunities and things, and before you know, your whole life can be taken up with it, and you almost forget what it's like having life outside of medicine. It feels really awkward when you have a day off and get to relax and do nothing. Sometimes I'm just sitting there twiddling my thumbs being like, I should be doing something. And so don't fall into that trap. And that links into my second point in terms of don't overcommit. You'll learn how to say no. General practice, and especially as a registrar, you do have the options of being flexible and crafting it to whatever you want to make, and working part-time if you want. And yeah, just being able to have a bit more time to yourself. What other points did I have? Like Amanda said, yeah, being involved in the community really helps. The big advantage of working rural is you're generally in a lovely area, lovely sort of environment and activities and things you can do. The community sort of people are generally incredibly welcoming and glad that you're there, because such obviously a shortage of doctors in the country. Now, it doesn't mean you have to be super social and joining sort of team sports and stuff. That's not your thing. You might be going out and doing bushwalking or skiing or riding a bike, something that's just gets you involved in the area and builds those ties. Certainly helps. And as we've already sort of mentioned, my other point was just add variety to your work. Don't feel you have to do 4 or 5 days a week of general practice. Add some other interests to make it a bit more flexible and interesting.
That is brilliant. Thank you. I'm starting to want to be a GP now, but I may have left my run a little bit late. But thanks very much. I'm just going to go on now. Any questions before we move on to just having a look at the VRGP Rural Generalist pathway?
I was wondering, just in general, in terms of making the transition from hospital work to community GP work, and going from a team environment where you're supported by lots of different people to being in a room by yourself with just the patient. Any tips on how to approach that?
Yeah, I'm happy to speak to this. I'm sure Chris has got some tips too. You're still part of a team. It's just not at the same time. So you know, there's other GPs in the practice, there's nurses in the practice, and there's loads of other people that look after the same patient as you. That might be allied health specialists, whatever. They're not in the room at the same time though, and that can be jarring and can take some getting used to. So, I mean, there's loads of support, and you don't need to solve everything for every patient in one consult. I remember being taught early on in my training that GP is like one long consult over weeks and over months, and you have this pressure coming out of medical school that you need to do in 15 minutes, you know, history examinations, investigations, diagnosis plan. That's not what happens. You've got time. You can get people to go and do tests and come back, and in that week before you see them again, then you talk to your supervisor, and that's how you get that kind of teamwork input. You've actually got loads of time. You know, their investigations come back and you've got a week to look it up before you see them again. So rather than sort of panicking when that person's in front of you and you have to come up with a plan, you actually just need a plan until their next appointment. You don't need a plan for the rest of their life in one consult, and you've got the luxury of all that time, you know, rather than looking something up in ED and you've got to tell the patient what their test result means within the next hour. You've got plenty of time to do that and to do quality work.
Any other questions? Chris, did you want to add to that?
No, I think
or did
Amanda
really well. Cover it comprehensively?
Which was pretty comprehensive. I will add, so you normally start off for the first at least probably couple months of your general practice time seeing one patient every 30 minutes. So you've got time and you're generally not sort of pressured as much. And really for sort of a first term registrar, all we don't expect you to know much at all. All we really expect is you can take a bit of a history and exam and maybe come up with a rough plan of what you're going to do. And you've got a supervisor there who's always sort of going to be attached to you for the day, for giving them a phone call or getting them to come into the room and look at a funny spot if you're not sure what's going on. So you're incredibly well supported when you start out. But I agree, it is certainly daunting, but you pick it up remarkably quickly.
I'm going to move on just to the rural generalist, then we're going to look at the application process, and believe it or not, we're almost at time. It's just flowing past. I've really enjoyed it. So I'm just so grateful to you all attending tonight. So I'm just going to share, can everyone see that adequately? Can you read that? That's a yep. So basically, a rural generalist is a medical practitioner, I will read this, who's trained to meet the specific current and future healthcare needs of, for you as one, you have to meet all the healthcare needs of the Australian rural and remote communities in a sustainable and cost-effective way. I'm not going to read the rest, but rural generalists, as Chris has mentioned, they basically have formal specialisations in things like emergency medicine and primary care. We're going to take a look at that very shortly. And sorry, going the wrong way. So a rural generalist, as we've said, is a subspecialty of general practice. And as you can see here, for a rural GP, it's MM3 and above for Racgp, FAR-GP, and MM4 and above for ACRM. Now, Chris, you said that there's more flexibility with the ACRM pathway too. There's other opportunities there as well.
Yeah, so
going forward.
In terms of the MM4 and 7,
yes.
so MM3, you can do part of your core generalist time. So generally you can get posted accredited for 6 months rather than sort of 24 months. So for example, Wangaratta, where I'm in, is MM3, and there are clinics that are accredited for 6 months of ACRM. But most of the ones which are accredited for 12 or 24 months of your training are your smaller towns, so 4 and 7. And as I was saying, the ASTs, that generally can be any MMM category, because we know there's something like anaesthetics or something, you can't do that in a MMM4 town. There's not the support and infrastructure there.
So you can see the sort of, I think for me, this is one of the best slides to explain what a rural generalist is, to give that key differentiation. Any questions at this stage before we move on? No? So just very quickly, is everyone familiar with the Victorian Rural Generalist Program in more than name only, or has anyone met with a rural generalist, a VRGP coordinator through their pathways so far? Is that a no?
I've met Merrin.
You've met Merrin, Steph? Yes.
I've also met Merrin. Yeah.
You've met Merrin, fantastic, because that'll tell me how detailed I need to get this. And Katrina, have you met Gemma in Loddon Mallee?
No, I don't think so, not yet.
I will introduce you to her if that's something of interest to you, because it's great to be able to sign up to the VRGP program, even just to discuss options if you are interested, or even if you have a passing interest in rural generalism. It's really great that they can actually talk through what the process is for you. So for both of you that have met Merrin, and for Katrina, Merrin is the VRGP coordinator for Hume, which is the northeast region, and basically she undertakes the coordination of the training pathways, which we're going to just go through. She helps trainees choose the right pathway. She assists trainees in navigating their way through the training requirements, links trainees with role models and mentors, and identifies opportunities. And Chris has particularly mentioned this, is lining things up well in advance so that you're not in any doubt about what your career pathway might look like. And for Emma and Steph, you're probably well aware of that, having met Merrin already. There are also the VRGP clinical leads who really support the rural generalists in the program with their their disciplines that they're training in. And I won't go into the rural networks, the regional networks, because that's the management part of the process, but I'll share this with you later on if it's of interest to you. The regional coordinators, as I've said, can assist you in navigating your way through the training requirements and career opportunities. And I think we've covered all of that. And usually I wouldn't be doing this. This is usually done by somebody who's not well today. So, but I know enough about it. So as you can see, that there is a pathway that starts in RG1, RG2, and then goes into the advanced skills training year with the VRGP. So this is a graphical representation, particularly for Emma and Steph. You may be aware of that. Katrina, is that something that you're familiar with? Putting you on the spot, apologies.
Vaguely.
So you are aware that basically you enter these posts. The fantastic thing about getting on these pathways, particularly if you're entering AGPT, is you're looking at lateral entry, and these posts are funded. So basically the advanced skills posts in the major regional hospitals are funded, and they're very well supported. And also the coordinators and the clinical leads provide a strong support network alongside MCCC supervisors and training advisors as well. Just what I want to mention here is that there are currently nine rural generalist advanced skills posts in the Northeast region. There are 9 in each of the regions throughout Victoria. So they're fully funded, and basically they, sort of, and supported for you to go through to achieve your rural generalist pathway. And in this case, it would be with Racgp. So the kinds of pathways which you all may be already familiar with, they're not limited to these, but these are the current ones that are available in the Northeast, or have been available in the Northeast. Anaesthetic for 2022, anaesthetics, obstetrics, emergency medicine, paediatrics, adult internal medicine, PAL care, and mental health. So you can see that there's quite a range, or there's quite a variety. It's not just procedural medicine. There are new pathways being built every year in terms of advanced skills posts. So these 12-month posts, and they're being built to meet the demands of regional and rural communities. So particularly in mental health, there's been, and palliative care, there's been quite an upswing in that. This year, there was a really huge uptake in anaesthetics, and not so much interest in obstetrics and emergency medicine. So, but that's just might give you an idea of the breadth of opportunities that are available by doing an advanced skill and a rural generalist pathway. And you can see where those pathways, those skills are, those posts are. Basically in Albury, Wangaratta and GV Health. I'll go back quickly. The consolidation program, Chris touched on it previously in his ACRM pathway, but basically the consolidation program is designed to enable people to use the skills that they've trained, the advanced skills that they've trained in hospital, in a smaller hospital setting and in practice. And so that basically is a key element of the rural generalist consolidation process at the end of your training. Chris or Amanda, do you want to say anything about that? I know we're getting close to, well, we are over time.
Yeah, so it's basically, what used to happen is, say you do an anaesthetic year at Wangaratta and then you'd sort of finish, and then there'd be next to no support, and you'd be left trying to find ways to keep up your skills, because you might be going to a small town that you might do a list of a fortnight or something, but not quite enough to keep the skills up, and it could be quite daunting, and a lot of people would just drop out and not use those skills. So where the RDC comes into it is there's this funding allocated, which enables you to do either regular lists at a larger hospital, or pay to have another rural generalist support you and do either lists or help doing cesareans or whatever your skill is. It helps keep those skills up and ease you into that smaller town environment. So it's a really useful thing and probably one of the big benefits of the Rural Generalist program.
And in the bigger picture, it is to get you really confident using those skills in the smaller communities. And I think, you know, that's one of the really exciting things. I won't keep you too much longer. So these are just some comments from people who are doing the Rural Generalist program. So I'll stop that share and just go finally back to the remaining. I just wanted to touch on hospital experience assessment and recognition of prior learning before we complete tonight. And just bear with me. So is anyone currently a bit bamboozled about the hospital experience assessment and what's required? Anyone wanting to know some more information about that?
Yeah, I have a question. I heard a rumor that in the future they're planning to make psych a mandatory prerequisite. Is that true in the next few years?
I'm not aware of that, Chris.
I hadn't heard that rumor.
If they are, it's certainly not in the immediate future. If you're talking about, you know, applying this year or next year, that's not something they're implementing at the moment.
Okay, thank you.
You can do it as a advanced skill, but it's certainly not something that is mandatory at the moment. Emma and Steph, any questions on hospital experience assessment and submitting that as part of the AGPT process?
I knew that there were like mandatory rotations required, but I'm not familiar with the actual assessment that needs to be submitted.
Amanda, can you speak to that?
Yeah. So it depends how you've done them. So the standard kind of pathway, if you're an Australian graduate PGY2, you'll have ticked these things off as an intern or as a resident, and your current hospital can just provide a letter, like a statement of service that you can give MCCC that confirms you've done however many weeks, you know, full-time working in this department. So that's the way that most people do this. There are other ways, and recognition of prior learning if you've come a funny pathway. So if you're not a resident at the moment, if you're further along than that, if you've been a registrar in another specialty for a few years, or you've been working in something else, there are other ways to do it. So one easy example, so I was working in the ED part-time before I started doing GP part-time, and I never got a pediatrics rotation as a resident because that was one that Albury-Wodonga Health had as full-time only. So I was able to count additional emergency time as pediatric time if I saw enough pediatric presentations. So I needed to demonstrate that I was seeing kids in a mixed ED at Albury, and that was accepted. So the easiest way is just do those rotations as a resident, but there are other ways around it, and it's a great thing to actually speak to MCCC about if you know you're in a sticky situation or you want to know if things will be accredited. Speak to people earlier rather than later.
And I'll follow this up with an email of contacts if you have any questions that you want to answer directly about hospital experience assessment or RPL. The other thing that I just wanted to mention too is with the intake 2 for AGPT, if you're considering this intake, I would suggest getting your hospital experience assessment, which you'll see in terms of the application. Get all the documentation in as quickly as possible. If you can get it in before, so basically you apply and then you submit your hospital experience assessment. There are so many opportunities that will open up for you if you can get your hospital experience assessment in probably before the 15th of October would be fantastic. And that will really help you, you know, sort of have a whole range of opportunities open up to you. I'm going to finish off very quickly. Anyone looking at RPL or needing advice around RPL or have questions about that at the moment? No? Okay. So I'll send this out so that I'll also send our handbook out with this so that you can have a quick look at some of those elements. That is also in the Racgp handbook. But for some people, particularly overseas doctors or doctors that have come from a different, you know, discipline, that it is quite common to have RPL granted, isn't it? Have either of you had RPL?
I personally haven't.
Yep.
I know registrars that have, and your example is spot on. So typically people that have practiced overseas before starting coming here, or people that have been in another specialist training program already. So if you were doing anesthetics training and you dropped out of that program, you now don't need to repeat a 12-month anesthetic year to get your anesthetic advanced skill ticked off. It's that sort of thing.
Excellent, thank you. So basically this brings us 10 minutes over, but I hope that it's been really valuable and highly informative for you. Any questions before we let Amanda and Chris go? All questions to me?
No questions, but thank you for your time, guys.
If you think of anything later, I'm just going to pop my email address in the chat bar. So as I said, I'm employed by MCCC as a registrar liaison officer, and that includes talking to you guys too. If you're applying to the program and you want to chat to me and you've got something you'd rather ask a current registrar rather than the office staff at MCCC, feel free to get in touch.
And I totally agree with you. That's why I was really keen to make this format, because I think having this absolute practical knowledge, Amanda's and Chris's practical knowledge of how things work in a framework that you can understand and in the context in which you're training and living right now is so valuable. I know I would personally prefer that, and I was keen to get that opportunity for everyone attending now. If you know of anyone else who's interested in this, I'll be sending you out the link of this recording as well. So please feel free to distribute that. I think all the questions tonight have been amazing, and I really thank you guys for attending what has been a very intimate webinar. And I want to say thank you, big thank you to Dr. Cohn and Dr. Pring. And I wish you all the very best with your applications, whether it be to Agpt IP pathway or to Racgp in the Agp intake 2. Don't hesitate. I'm a great finder of information, so don't hesitate to contact me and or Amanda if you need any more information to follow up to make your application, you feel confident about your application. Thanks so much one and all, and thanks for allowing us to go a little bit over time. Thanks everyone. Thanks Chris, thanks Amanda, thanks Katrina, thanks Emma, and thanks Steph.
Thanks, guys.
Thanks, Anna.
Thanks so much.
Thanks.